Welcome back to Guardia di Medicina. We really appreciate you tuning in today. I'm very excited because I get to have one of my close friends as a guest on the podcast. We got Dr. Joseph Marcelli. He's a doctor of physical therapy, and he currently works up in Cleveland. And full disclosure, he just recently got engaged to my sister-in-law, so congratulations.
Thank you.
Joe, it's a pleasure to have you on today. Would you mind telling our audience, what you do on a daily basis and where you work at?
Yeah. First, thank you guys so much for having me on. I've been listening since you started already, so I've been an avid listener.
We appreciate that.
Yes, definitely. Thank you.
I'm excited to be here. I'm a physical therapist. I've graduated 2 years ago, so fairly new in the field still, but starting to get some experience. And I'm in neuro rehab primarily, so I work with a lot of people that have had strokes or like spinal cord injuries or even just general like imbalance, deconditioning. And then in addition to that, I treat a lot of like dizziness and vertigo and things like that. And I work for a hospital system, so there's some bleed over into like orthopedics and a little bit of everything basically, but those are primarily the patients I see.
What is your favorite type of patient to take care of?
It's probably the vestibular stuff, so vertigo and dizziness.
Interesting. I would expected you to say like either the stroke or the spinal cord injury based off the things we're going to talk about today.
Yeah, well, I mean, they're pretty close, but those are really fulfilling cases to work with. But the vertigo stuff is just really interesting and unique. You get some quick wins, and there's obviously challenging cases, but the quick wins are kind of cool and interesting.
While we have you here, would you mind telling our audience exactly what vertigo is and what are some of the things that you do to help those patients? Because I know that there's a disease out there called BPPV, which stands for benign paroxysmal positional vertigo, that is much more common than people think, and it's a little crystal that gets stuck in the inner part of the ears and causes dizziness. And I know there are other things as well. Can you talk to our audience about some of those things that come in on a regular basis?
Yeah, so with BPPV in particular, it's position-based. Vertigo is a symptom, so people will get sent to us with a diagnosis of vertigo, and that's not really the diagnosis. Something's causing the vertigo typically. So that's the symptom, and that's true vertigo is room spinning. So if it's BPPV, it's usually positional, and it's that crystal is kind of floating through a canal in your ear. And once it settles, the vertigo stops, and if you move again, it starts to float again. And basically, we go through some testing in different positions on a bed, and try to get that crystal to fall out of the place that it's at, to put it simply, I guess. And then the other causes of vertigo are, it could be something central, meaning coming from like your brain, or it could just be another like inner ear weakness or infection or something. So we're trying to differentiate all that kind of stuff.
That's very cool.
That's wild.
Yeah, that is very cool. What are for the central ones, the ones that come from the nervous system or the brain specifically? Are there quick, easy fixes for those, or is that something that's more long term?
Probably more long term. It can be hard to kind of suss out, and then depending on the severity, it could range from like a tumor or something even, and that requires neuro consults and maybe surgery, or it could be something, for our older populations, like microvascular changes, and we do what's called habituation, which we're just trying to get people to kind of recognize certain things as normal again and get your brain to, it's like graded exposure essentially, get your brain to recognize stuff as normal.
It's like, go ahead, I'm sorry.
Forgive my ignorance. Like, do you guys work pretty closely with like radiologists, do a lot of imaging and stuff? Because I would imagine that has to play into.
So we're not, it's not in our scope to refer for imaging. We can't order imaging or anything like that.
Right, okay.
But we work closely with, especially primary care doctors, and saying like, this doesn't seem like a physical therapy problem. You should probably consult again and maybe send them for this sort of imaging or other specialty consult.
We're going to get into this in a little bit as well, but when physical therapists tell the primary care docs, and I know my audience knows this, but I'm a primary care doctor, we'll get a message back from the physical therapist saying, hey, this is not a physical therapy problem. Guess what? That's when insurance companies will allow you to get the appropriate imaging studies ordered. So, for example, we're talking about spine injury specifically. the insurance companies will want to see 6 weeks of physical therapy before they approve an MRI, which sometimes is outrageous. But if the physical therapist comes back and says, hey, doc, like this person can't do anything, then that is a clue that we're allowed to order an MRI test
see.
and get it approved, which is kind of insane, but it's, you know. And then also you mentioned brain tumors for central, getting back to vertigo, you know, central reasons for vertigo. You know, why would you want to delay diagnosing a brain tumor? It's like, come on, you know, it's just kind of crazy. Why would you want to delay going back to regular spine or orthopedic problems? Why would you want to delay a severe herniated disc and severe lumbar spinal stenosis? Just very disappointing on that front.
From a PT point of view, I guess the imaging is, we go back and forth on. I mean, I think if you're ordering an image, if you think that there's a need for an image right away, that should totally be approved. I think some of the like literature supports a lot of stuff, especially orthopedic issues, can be solved with physical therapy and conservative measures. And sometimes imaging can lead people to chase. I mean, most people probably have a herniated disc, and it might not be the cause of pain. It might be
Right, it might just
chronic.
be there, and it might not. It's
Yeah.
because you have a herniated disc doesn't mean you need surgery all the time either.
And sometimes people get caught up on, well, my image shows this. And
Really interesting
they'll
perspective.
want the surgery. So I get why sometimes they might require that, but at the same time, if you see signs that there's a brain tumor or something central for the back going on, and they say you still can't get an image unless you go to PT first, because I've had that happen where someone's come in and they need PT, and I'd send them right back. I'm like, you're losing leg strength on a weekly basis. Like this is not not something we can fix. So
I'm curious to hear how much that you're hamstrung by insurance stuff, like both of us have been in our career, because it seems to be a common theme between medical professionals that the hoops we have to jump through.
Yeah, and more specifically, you know, I've seen patients that, you know, for my assisted living patients, and for those of us that don't know, assisted living is where patients go and live at if they're elderly and they start to have physical deconditioning. I can only get a small number of sessions for physical therapy approved to decrease the fall risk. That's the one that comes to mind to me. Do you frequently find that, Joe, you know, in regards, you were talking about vertigo before, or stroke patients, do you find that you get your sessions cut off, you know, sooner than you would like?
yeah, definitely. It seems like more and more companies are moving towards like prior authorization models for insurance. So what that means basically is you can come in and see us for an evaluation, but then to get follow-up treatment visits, we have to submit to your insurance company and ask for however many we think it might take. And then the insurance company comes back and says, well, I mean, typically they say, we'll give you 4 out. Like if I request 10 visits, they'll give you 4 or 6.
That's so crazy.
I mean, sometimes there's good ones and they'll give you what you need, but oftentimes it's coming back with like half the amount you request. And it's usually a delayed process also. So, I mean, if you come in and see me for an evaluation, we won't hear back for 2 or 3 weeks if they're getting backed up or something. So
It's a long time.
That's incredibly frustrating, because they're essentially saying, like, hey, you as the professional, this is what you're saying they need. We're going to go with less than 50% of what you say. And I would imagine that makes doing your job very difficult.
yeah, and I mean, it's essentially like these companies are practicing medicine, because I mean, we're the licensed provider. I mean, same with you. If you're ordering an image and they're denying it, they're practicing medicine in a sense, and we're the clinicians that are trying to defend our license at all times. And
It gets very confusing because it brings up the question of, well, is the algorithm the one really being the provider at that point? And what do I mean by algorithm? I mean this computer system that the insurance companies have created to evaluate, you know, what they're going to pay for, what they're not going to pay for, essentially what they're going to allow, what they're not going to allow. And this algorithm is the one that makes that decision. But when we ask these companies, you know, Cigna, United Health, Blue Cross Blue Shield, when we ask them, hey, what is the algorithm? Can you show us so we can understand it better and give patients better care? They'll say no.
It's proprietary.
Yeah, we're just not going to share it with you.
And as the license holder, you're also carrying the liability. So you gotta pay for schooling, you gotta carry the liability, and then you have to try to make it work anyways, despite these decisions that are being made about the people who are paying boatloads in health insurance every month. They still have to get their care chopped because these guys gotta make their piece of the pie, and that piece seems to get bigger and bigger.
It really does. Joe, if you wouldn't mind me asking, how much does it cost to go to physical therapy school?
Well, so it's 4 years of undergraduate, and you can rack up as much debt as you want there, going public or private.
In-state, out-of-state?
Yeah.
Yeah, I mean, so that's your bachelor's degree. Then you have to apply to a doctorate program, which is an additional 3 years, which ranges probably from like 60,000 by the end of it to, I mean, again, you can go private or out of state, and you could probably come out with 150, 200,000 in debt.
Wow.
Plus your undergrad.
And for the people listening that haven't gone through this, that debt starts accruing interest as soon as you take it. So it's not like we used to have subsidized loans. We had them for 1 year when I was in pharmacy school, where they didn't start accruing interest till you graduated. Unfortunately, that's not the case anymore. So all the loans do accrue interest the moment that you take them. So if your schooling costs $25,000 a year, that $25,000 is ticking up while you're in school before you can really start to pay it back.
Mm-hmm. Joe, what would you say is the thing that excites you the most about physical therapy in terms of the patients that you work with and the future in terms of what you feel things are going to improve upon for care for patients?
So I'm excited that it seems like more and more people are choosing like conservative treatment routes. I think that's really good for my profession in particular, but people don't want to take opioids for their pain. They want to avoid surgeries. So that's good for us. Our profession in general, since it's moving towards this, or it is a doctorate program, and it's been, but we're more of an evidence-based field at this point now. And I think that's led to us gaining respect among other healthcare providers.
That has to feel really good too.
Yeah. And I mean, yeah, we used to be, people would say, go try PT for your back pain. It's probably not going to work. Come see me after your 6 visits. And, you'd get a hot pack thrown on you and it didn't work. And we're much more sophisticated now in terms of, we know the things that do and don't work. And yeah.
Would you say that and I think that's awesome that when we talk about evidence-based medicine, I think that is really cool. That's a huge development. What do you think in terms of technology, though? What sort of things, in the either AI field or in other aspects of technology, how do you think those may come into play in the future?
Yeah, so that's definitely the other area where there's a lot of excitement. I think AI is going to make like our documentation lives a lot easier. I think there's lots of cool tech especially in the neuro realm of restoring function for like spinal cord injury and stroke and different foot braces or AFOs or for your knees or whatever kind of a brace you might need. There's a lot of cool stuff in the works there, it seems.
Mm-hmm. Yeah, that's all really exciting. And I'm also fascinated, the combination of orthopedic surgery and physical therapy for musculoskeletal health, that is kind of our next, other than neuro, that is our next realm of trying to see what we can do to improve patient care because we're living longer, but that doesn't mean our quality of lives are better. So we have, patients getting up into their 80s and 90s with physical deconditioning. The question becomes, well, what can we do to prevent that physical deconditioning? Just like on the neuro side, what can we do to prevent the cognitive decline? And I'm very curious to see what type of technologies both the orthopedic surgery field and the physical therapy field come up with to try to help with those types of things.
Because as you age, moving around is extremely important.
So critical.
If you stop moving around, stop going on. Like my grandpa used to go on walks around the mall during the wintertime because it was too cold to go on walks outside. So he would go to the mall and walk. My grandpa lived in 93. He had like 100 pack years of smoking from working at the mill, and he liked his red wine, but he was moving his whole life, and then eventually slowed down. We all slow down, but I think that both of you can probably agree with me that ambulation as you age is very important.
It's one of the most important things, and there was a stat out there that once you stop moving, if you have a broken hip, there's a 50% mortality that you will not there's a 50% chance you'll not be with us in 1 year.
Yeah.
Which is crazy. Obviously, the broken hip has complications itself from surgery. That's a major surgery to fix it. But the main concern is that, well, then after surgery, you're not moving anymore. And then that can lead to all types of things. Another, and Joe, please tell me if this is incorrect. Another stat that I had come across was for a patient over the age of 80, 1 day in the hospital correlates to about 2 weeks that it would take for them to regain that strength from laying in the bed for 24 hours. Have you heard anything like that?
Yeah. I'm not certain on the number, but that
Sure.
sounds close. And I often tell my patients something similar to that. And that's why falling is the F word in physical therapy, essentially. I mean, we want older adults to not only continue to ambulate, but strength training is kind of like the main thing that we preach all the time, and maintaining your muscle mass to prevent the fall from happening in the first place. And then inevitably, when you do get sick or hurt, you have a higher baseline that you can get back to normal easier from. But yeah, if you kind of neglect those things, it is more like the 1 day will cause 2 weeks, and often you're not in the hospital for just 1 day. So
Yeah, of course.
I've always read how important strength training is as you age. Like, I'm not talking about bodybuilding, but just doing some sort of weight bearing exercise, moving a little bit of weight around is very important, just as much as cardiovascular workouts.
It really is. And, so we're talking about increasing or decreasing our fall risk.
Yeah.
Obviously, what happens to those patients that, you're trying to decrease the fall risk, but they also, recently had potentially a stroke and have a neurodeficit on an upper and a lower extremity? How do you work through the insurance companies of trying to handle both situations at the same time?
So it just becomes a much more complicated case, essentially, with the insurance companies. I mean, the case in general, I guess we would phrase that still as just deconditioning or like a gait abnormality, and they're at high risk of falling, and we're trying to get them back to normal life and function. I guess the main limitation is still visits and requesting visits and eventually being cut off by the insurance companies. I mean, I've seen people, and they've come in with a Parkinson's diagnosis, and the best way to prevent decline in function is exercise with Parkinson's, besides whatever pharmaceutical they might be on. And I've gotten like 4 visits approved, and there's nothing we're going to do in 4 visits that's going to, have a long-term effect besides education,
Yeah.
I guess. But yeah.
I mean, that's just despicable. I know with the pharmacy measures in Parkinson's, we use carbidopa, levodopa mainly. But the thing about that drug, or the combination of the 2 drugs, is it stops working eventually. And then they increase the dose, and then that dose stops working. And that's something going into it. But there aren't a ton of options on the table. But I would think even from the insurance company's perspective, and I guess I have to be wrong because I'm sure they would look at this, but it seems like it would be cheaper to keep people healthy and to give them the visits that you request, and rather than deal with what happens when you only get 40% of those visits and then you go home and fall and then you're back in the hospital and, all those dominoes. From the surface, it seems like it should be cheaper to listen to you, the professional, and keep the people healthy and out of the hospital. But again, I must be wrong.
Well, on the surface, I guess it's time to put our tinfoil hats on because, yes, of course, that makes the most sense. But I would argue that the people that own these insurance companies, and once again, your boys, BlackRock, Vanguard, State Street, who also own each other the most as well, I don't think they're interested in keeping people healthy. So to me, if you think about it from a different perspective, rather than saying, hey, we want to use physical therapy as a modality to keep people healthy, if they say, hey, we want to use physical therapy to make a little bit of money, but then go on to still develop whatever disease, X, Y, or Z, and then we can charge them for the treatment of disease X, Y, or Z, I think that is probably more profitable than it would be keeping them out of the hospital. So, for example, if they fall and break their hip, well, then, the insurance companies are then getting money from the equipment that is used to replace the hip from a hip fracture. They're getting money for the medicines that we have to purchase to put the patient under anesthesia. They're getting money for, now the patient has to pay money to go to an assisted living facility. So
So being involved in the system, you're saying, is the goal.
yes, That is the goal. And physical therapy's goal is to keep patients out of the system.
Right.
So I can easily see why they deny a lot of your claims, is what I'm saying. I'm not saying that's right by any means. It's just my own personal opinion as to why that happens.
But then I would love to hear somebody else's perspective, though. Anybody comment or whatever on why else they would, cut the visits that Joe recommends.
Right.
What is the benefit?
What is the benefit? And I would love to hear a logical explanation as to why I'm wrong, but I can't seem to think of any because it truly doesn't make any sense.
Yeah, I mean, that's a lot of time the biggest frustration is that exact kind of order I would expect is we're trying to keep people out of the hospital. I'm trying to prevent that hip fracture. We're trying to keep the person with Parkinson's walking. And if we're cut on visits, that doesn't happen.
The crazy thing to me about all this is the healthcare professionals are making less money. Insurance is there. It should be there for, medical insurance should be there to help you with everything, but also to cover you in catastrophic events. It seems like it doesn't either. It seems like when you have a catastrophic event, you're still putting a second mortgage on your house to pay your bills. And then when you're actually going to your regular visits or your maintenance visits or whatever you want to call them, you're still paying out the butt, and those people aren't making any money.
And then you're still paying for the medications that you need chronically.
Yes, and the pharmacy's not making any. Like, all of these medical practitioners, in theory, could get together, remove insurance, and go, hey, we're going to charge you a cash price of X. It's going to be way less than you pay your insurance. It's going to be way more than we make from insurance, and you're going to get the care that you want. And I don't know how to make that happen. It's such a complicated system, but in all of our cases, we could charge patients directly less than what they pay into the system elsewhere and deliver way better care.
And we would make more.
Yes. By charging them less, we would still make more money.
We would still make more. And I can't believe I'm uttering this into the microphone, but we need to consider unionizing. That might not be the right term. And God, I hate that I'm saying that, especially
the tingle
across,
that just went through my body.
Especially sitting across the table from you, of all people. That
But
I
you
have
can
to say
call
that.
it something else if it makes you feel better. You don't have to call it a union, but we can call it whatever we want to call it.
But it is the truth, and I say that because the power is lying in the wrong place. This isn't even about power. This is about doing the right thing for our patients. But in order to do the right thing, we have to have the ability to make those decisions. And sometimes we just don't. And then on top of that, you made mention of how much it costs all the, the average person. I'm going to use Eliquis as an example. Eliquis is a medication that is a blood thinner that is used for sometimes in patients with atrial fibrillation if they meet certain criteria to prevent risk of stroke, and then also blood clots. Really important. They meaning the makers of Eliquis, the manufacturing companies, make the price so high that the average person has no ability to afford it whatsoever. None. And then when the insurances, quote unquote, don't cover it, it's going to cost the patients like $500 out of pocket per month.
So in pharmacy, people that own pharmacies know this. The first of the year and the 1st of July, the prices of all brand name drugs go up every single year, every single time. So when I had a pharmacy, Eliquis, if I'm 60 Eliquis, cost me to buy from my wholesaler somewhere around $470. I can't remember exactly, but it was, eventually it was over $500 because, like I said, twice a year, the price of all brand name drugs goes up.
And then if you turn around and sell that to the patients, you have to charge them that much money just to break even.
Well, I charge them sometimes they have a copay of the whole amount and I lose $50. Let's say it cost me $500. They have a copay of $450 and I get nothing from the insurance company. So I light a $50 bill on fire. The patient pays me $450.
And they're mad at you thinking that you charge them. Yeah.
Yes.
It's just crazy. It's crazy. Joe, getting back to one of the other topics that we were looking forward to discussing today, because I don't want to dwell on too much of the insurance issues, even though I could dwell on it all day. I want to get into the exciting things that we talked about before with the neurologic advances in physical therapy and some of the things that you have seen, specifically with your stroke patients and loss of function of, let's say, your left arm or your left leg. What are some of the things that are out there that you really look forward to working with?
Yeah. So the main thing that we see right now is like functional e-stim devices. So basically, there's a lot of use of AFOs, which is an ankle foot orthosis. So basically, when you have a stroke, it's going to affect one side of your body. Typically, it's going to result in some weakness of your leg and arm on that side. And you get things like foot drop, or your knee gives out, and that sort of a thing, which interferes with your walking and can cause you to fall, or you just can't move around as well. So, on top of trying to strengthen and restore these things, we use compensatory devices called AFOs. And the cool ones right now are the ones that are kind of sync up with your natural gait pattern, and kind of will stimulate those muscles for you to go upstairs, or just timing with your walking. And
That's really
That's
cool.
wild.
instead of a rigid plastic brace that used to just hold your foot up.
Can I ask you a question? How does it do that? How does it sense the patient's movements?
So there's a like accelerometer, the things that are in your phone that detect you looking at your watch or your phone even, and they'll light up the screen. I just can't remember the name of it. But so basically, someone will come in and they'll work on syncing that up with your gait pattern, and it'll be through some video analysis typically, and just some trial and error essentially, to get that eStim device to fire those muscles in the moment you need it.
So there's a device inside of the eStim. And by the way, for those of us that don't know, eStim stands for electrical stimulation. For these eStim devices, there's a device that almost is like a video recognition camera, and then also a sensory camera, or not. I don't want to say sensory, but it senses, when people are moving, and it senses, and it has the ability to see what part of your body you're moving.
So the video is more from the clinicians or the rep side in terms of getting it all to work correctly. It's more of the sensors inside the device. I think it's an accelerometer, or whatever those things are. Is it a gyrometer? Or,
Maybe. I don't know.
I can't think of the
I don't know.
That's really
the engineering
cool, though.
terms of that. But yeah, it's sensing your acceleration, deceleration, and those sorts of things.
I would imagine this is something that AI hopefully is going to continue to improve on. This seems like something that there's an opportunity there, at least.
Huge. What do you think is the next generation to this, Joe?
So maybe I think AI might play a role in learning with your movements, I guess, and in terms of if you're getting stronger and better, maybe it more naturally adapts to that, or the environment that you're in. So like right now, if maybe you can slow down or speed up a little bit more efficiently. I think the next phase, though, is probably things like what we've seen with like Neuralink, or more direct central nervous system involvement, where we're almost restoring function by reconnecting those central nerves.
And it's so crazy, and I just want to take a step back and explain, a little bit about how Neuralink works. And I only know this because Joe shared this with me. I did not know that it worked like this. But let's say if you have somebody that is paralyzed, and when that patient thinks about moving their hand, even though they can't, small signals, not signals that are as, I'm going to call them loud, but not as signals that have high as amplification as when you actually are moving your arm. But if you think about moving your arm, you still send small signals in specific parts of the brain. Neuralink literally interacts and interfaces with those specific locations in the brain to say, let's say if you think about moving your index finger, it'll have a little robot. Neuralink will be linked up to this robot. Okay, I want to think about moving my index finger, and then it'll move. And then the beautiful thing about Neuralink now, and this gets into the, correct me about the pronunciation, but the psionic hand, did I say that correctly?
Yeah, I think psionic
ability hand. If you touch their index finger or their middle finger, the brain will sense that that is being
crazy.
touched. But it's the robot, not even attached to the person's body. So that is really cool. Have you worked with any patients with Neuralink yet?
No, so this stuff is really, really early in its development still, I think. We're not seeing anything like this regularly, but it's the videos and the few clinical trials are cool to see and speculate about, especially for our spinal cord injury and patients who have lost that stuff, you know.
Yeah, that has to be so exciting to even think about. If in 10 years though you can have somebody that had a horrific accident and was paralyzed from the neck down, to even consider that they would have the ability to have somewhat of a normal life is truly fascinating.
That's awesome. Neuralink scares the pants off me.
Oh,
I'm
we're
not
gonna
gonna
get into
lie.
that. Yeah, tinfoil hats are incoming here quickly.
But those use cases are incredible. That's the way that this kind of technology should be rolled out, and the way that we should be studying. And I mean, I imagine a lot of that is going on, but I mean, with everything that we have this podcast for, plugging a chip into your brain and letting somebody else have full control of that,
That's why we're here.
scares, and not only somebody, probably the richest man in the universe.
There's no doubt, and it's not just one man; it's multiple men.
Yes.
But I went like 17,000 steps ahead with that statement there because I can't wait to get to that part. But just going back, just thinking about the beautiful thing of Neuralink, so the chip is inside of the human that is paralyzed, and then the robotic arm is outside of the human, but yet somehow the person will be able to tell what finger you're touching.
So I think that's
crazy.
That's the psionic one. That's
the psionic
it's
ability.
more of
Excuse me, you're right.
They're stimulating the part of your brain that would normally detect sensation in your finger or your thumb or whatever, because those things are still intact. You know, if you have a spinal cord injury, it's like cutting the external wire that runs from the outlet to the mic or the light. So the outlet still works, the light still works, but the wire's severed. Mm-hmm. So you can still stimulate the light in a different way and get it to light up. And that's kind of what that is doing. I think Neuralink, they haven't used it yet in any like restoring limb function or anything yet.
Oh, really?
But it's still, so that's more of the opposite. The brain is telling the chip to do something, and then like right now they've used it for gaming and computers mostly, probably because that's the easiest thing to start with, and people can move a mouse or play a first-person video game just with their mind and thinking those things, basically.
Can you expand upon Neuralink gaming a little bit? Because I found that fascinating, and my mind immediately went to, okay, are we trying to simulate reality? You know, are we trying to take the last biologic thing that may be present, aka the mind, and then just put a bunch of electronics around it and you just interface with that? You know, when you saw that for the first time upon your research, you know, what were you thinking when you can just simply think about looking at somebody on a computer screen and shooting them in a game and that person gets shot?
Yeah, I mean, like I said, I'm not sure. I guess going more tinfoil hat, that could be a possibility of some sort of like simulation or something that you could put people into. I mean, my thoughts at this point are just it's probably easiest to make a mouse move rather than an arm or something. So it probably will get to both points at some point.
That's just so crazy to me. You know, and by the way, it's just so everybody knows, Joe introduced me to the Neuralink gaming. Have you heard of this at all?
I saw a little bit about it. Yeah, there was a guy that was, I can't remember if it was Counter-Strike or what he was playing, but I did see the guy that was able to play a first-person shooter with Neuralink.
So crazy. And if people don't know what that means that, you know, the point of view from the game is yourself, and you are the person doing the shooting. And all this person did, and by the way, I believe they were paralyzed, and somebody please correct me if I'm wrong, they thought about shooting somebody in the game.
He's still watching a screen. He's
still watching the screen, but he's thinking, I want to shoot this person. And he looks at the person, and then the game shoots the person. That's crazy.
I don't know how well he performed, to be completely honest with you, but
I think he performed
pretty good.
I think he performed better than like most gamers because he didn't have to take the time to like aim.
If it's
and
Counter-Strike specifically, that's unbelievable. Because I know you don't know anything about Counter-Strike, but there's a community of Counter-Strike players that play that religiously and have for 15 plus years. It's like a competitive arena shooter. So if you can perform well in that says a ton about how accurate the technology is.
I would love to hear from the, was it called counter-shooting?
Counter-Strike.
I would love to hear from the Counter-Strike community and educate us on this.
Please do.
Yeah,
please, yes.
Counter-Strike community, we need you. All right. Now, this is the point of the conversation where we're going to start to loosen up a little bit and have some fun with our tinfoil hat stuff. I want to talk about Neuralink specifically. One of the things that, we get worried about with stuff like this is, can Neuralink ever be synced to some type of big database system? And obviously that can have huge benefits. Do you ever see that being a possibility where, the Neuralink device may get synced to a huge database system, and then the person would essentially, that has the Neuralink chip device implanted, be able to think to themselves, oh, I want to watch ESPN, and then ESPN magically appears on a screen, or even one step further, magically just appears in their mind's eye?
Yeah, I mean, maybe. I guess I'm not sure. I'm sure that's if they're able to think about Counter-Strike and turn and look at someone, I'm sure they could get, the ESPN app to then pop up over it. I'm not really sure exactly how immersive it can become. I mean, it purely off speculation, I guess it's possible.
Mm-hmm.
Yeah.
And, I'm going to only speculate here, and I'm going to act like, I know what I'm talking about. But the honest truth is we don't really know where any of these things are heading. But, when we think about if you can get synced up into a database system, your mind immediately goes to Peter Thiel. And I think, he kind of did this to himself, right? He's a big tech giant. And Neuralink, for those of us that don't know, most of us do, that's owned by Elon Musk. You can easily see the connection there where those two gentlemen meet and have a discussion about how they can improve their products and make a profit. What's scary is, like we talked about before, is Palantir can lead back to the government. It's got government tracings that, tracked Osama bin Laden and found Osama bin Laden, assisted our military. And it is going to be one of the most powerful databases in the world. And if it syncs to patients with that Neuralink chip, who knows what the possibilities are? What if this person can all of a sudden think, well, I want to take out $1,000 from my bank account. Could they do that? Could it be linked back to a banking system? Could they think to themselves, oh, I want to DoorDash food? Could you start having phone apps?
I'm going to bet on Ohio State.
I'm going to bet on Ohio State.
Without even having to touch your phone, which is already crazy that we can bet from our phones. But if you just had to think, all right, I'll throw $50 on this game and then it's done. I mean, you could see the addictive properties.
Or let's say, hey, I want to make this link back to a Chat GPT, and you think of a question in your head. And then just like Chat GPT, it spits out several different ideas and answers to you. Can you have that all at one time? I think that's where this is heading, which is kind of crazy.
I mean, if you can have a chip control your limbs, you can have a chip control your body.
You can have a chip control your thoughts.
I mean, the sci-fi brain in me is thinking of, activated sleeper cells and conducting government operations or turning into an army at the click of a button, all that kind of scary. That's the stuff that really scares me. But I think it comes along with this territory. If you have the ability to do incredible things and restore function, then you do have the ability to do some scary things. And that's where we hope government steps in. That's where, in my opinion, government needs to step in to say, look, there's a way that we need to use these technologies, and there's ways that we need to go, like, this isn't part of that. And all this is brand new, so we got to figure that out before it's too late.
And I'm not aware of any oversight. Joe, are you aware of any oversight on these things that you've come across in PT?
Not, I mean, in terms of those
Neuralink or anything else that involved with e-stim or electrical stimulation?
I mean, the Neuralink stuff, no. I'm not aware of it directly, no.
That's
I would have to look into it. I don't want to say there isn't anything that exists.
I'm sure there's basic ethical things that go into it, and people that are willing to do an experimental trial. I think there's ways to go about that.
Yeah, I will say, I mean, a lot of the people that come in and work with us with those devices they used to be clinicians, so they have ethical standards that you need to maintain to have a license and be professional in that field. So I just don't think things are advanced enough yet to need heavy oversight into something like that. I mean, because it just it stims your ankle muscle.
Sure.
So
yeah.
So
sure, yeah.
But yeah, I mean, like you said, you probably need to get ahead of it in terms of like the Neuralink and this other stuff.
For people with limb loss, and this just popped into my head, have you seen anything where limbs are being replaced and they have any type of regain of function, rather than just a normal prosthetic? Have you come across anything like that?
No, it's still mostly just prosthetics. I mean, some prosthetics are pretty advanced now, and just in terms of trying to replicate like a normal foot and how it reacts and responds to each phase of like a gait cycle, but nothing like robotics still. I mean, it might be out there, but it's not practical probably for your average person who has an amputation.
Sure.
Yeah, I don't think insurance is going to cover that one.
So, I mean, that is the other, I guess with all of this stuff, going back to insurance companies, it's hard to get covered a lot of times because it's often considered like experimental for the patient. We don't know if it's going to even work or how effective it's going to be in regaining their function. So like for this the electrical stim AFOs in particular, oftentimes patients have to be able to pay for it themselves or have that possibility in mind because their insurance company might deny it and say, you know, this is an experimental thing. We don't know if it's going to work, so it's on you to pay for.
How much would that cost out of pocket? Do you have any idea?
$1,000 to $3,000 or so.
Yeah, so it's
I
not
mean,
going to happen for most people. I mean, it's impossible.
Yeah, I can't remember the exact number, but yeah, it's pricey. You know, it's something the insurance company you would expect to cover. You know,
How much or what percentage of time, in your experience, and I know that you don't know the numbers off the top of your head, just best guess, do the insurance companies cover the electrical stimulation devices versus how many times they try to have the patients pay for it out of pocket?
pretty often I see the patient has to cover it or be ready to cover it, I guess, because again, you just don't know if it's going to work. So oftentimes with every patient, you're having the conversation, you know, if this doesn't give us the outcome we want, then you're going to get the bill probably.
Double whammy for the patient then. You know,
Yeah.
it doesn't work and I got to pay all this extra money. And
That would be extremely frustrating.
and that's, again, I know that insurance has to put some sort of guidelines in and make sure they're not paying for things that don't need it. But when you're in a place that you're doing something experimental, like you're at a, I don't want to say desperate, but you've exhausted a lot of options.
Mm-hmm.
There's still people trying to live a better life, and somebody behind the scenes clicking a button to generate extra money, it just leaves a sour taste in my mouth.
Well, it goes back to the one algorithm that we talked about before, where we talked about the dial and PXDX. PXDX is a Cigna-owned algorithm-generated ability to review claims, and they're currently getting sued because when they used that algorithm PXDX, it found that they were not only denying more claims than appropriate, but they were also only having humans review those denied claims for 1.2 seconds, which means that they weren't having humans review them at all. And then now people like Joe are stuck with only doing 4 physical therapy sessions out of the 10 that they wanted, and it's just obviously very frustrating.
And even if they're found liable, then it comes down to that old equation of is it more profitable to do this and pay out lawsuits than to not do it?
Right.
And again, this is crazy.
And until we make the lawsuits so heavy that the penalty is going to be worse than the benefit, then it's just going to keep happening.
It's just a fine. It's not any punitive action. You're just fining these people. It's just they're going to keep doing it.
Just to bring it back to a football example, the Patriots are going to keep filming everybody's plays if you're only going to find them a 7th round draft pick. They only stopped filming everybody's plays when you find them a 1st round draft pick. So that's just an example of you have to make
the punishment fit the crime.
Absolutely.
Yeah, and I'll say we're allowing them to get away with it, I guess. From a patient perspective, we always try to encourage people you have to be your own biggest advocate. Sometimes all it takes is a phone call, and we've had people get more visits. You just have to call them and fight them or threaten a lawsuit or something against them. I mean, because at the end of the day, that stuff probably isn't, the lawsuit's going to be more detrimental if more and more people do it. So, I mean, we can do things on our end. We do what's called like a peer-to-peer, where you try to call and you get somebody who's not your peer telling you they're not going to give you the visits. But I mean, it seems patients have to fight for it themselves also and just really be your own biggest advocate, essentially.
And it's hard because usually somebody that's coming to see you isn't really at their best. You know, they don't have a lot of extra energy to make these. They're doing stuff also to make their life continue to run while they're doing these visits and trying to get better. Now they got to spend hours on the phone trying to threaten the insurance company, who they pay a ton of money to every month, to pay for this therapy.
I would challenge anybody that doesn't value that statement when you're going through a super low point in your life with either anxiety or depression. Try to call somebody and think clearly while also getting angry at the same time, and make, appropriate adjustments on the phone as to what the person's saying to you. That's not easy to do.
No. And it's a part that we shouldn't have to do.
No, I agree with that too. It's kind of crazy we even ask people to even try to have those kind of difficult conversations because, they're not trying to. They're just trying to get help.
But like you said, you have to be your own advocate, or you have to have an advocate. And I tell people that all the time. If you're going in the hospital, you have to have an advocate, somebody there that's going to keep an eye on stuff, not because of any sort of clinical incompetence, but because the way the system is set up, that if somebody's not there double checking everything, you might not get the best care.
Mm-hmm.
Yeah, and that's probably, like you said, not because of competence or anything, but I mean, the providers are overworked because the hospitals aren't being reimbursed enough to pay for them, and you have to push numbers and things just slip through the cracks. I mean, even like authorizations, that stuff gets delayed a few weeks. So I always tell patients, we're very busy. We do lots of these prior auths, every day. If you don't hear back from us in 2 weeks, like, give us a call. I didn't forget about you. But we don't want to forget about you either, So call and bug us, and we'll get on top of the company then to hear back. And we want to get you in. It's just, there's a lot.
For sure. Joe, as we kind of wrap things up and close things up here, what is one piece of advice do you have, not being that far out from graduation, that you have for current physical therapy students?
So I would say make sure you're going into physical therapy or healthcare in general for the right reasons. You have to be passionate about, wanting to help people and to be in this field, because it's tough and there's a lot of barriers and a lot of roadblocks and things to fight through. And it can be demoralizing, I guess, but helping the patient at the end of the day is what keeps you in it. Mm-hmm. So yeah, I would say as long as you're passionate about that, you'll make it. But it has its difficulties.
Sure, there's no doubt about it. Joe, is there anything else that you want to leave impacting wisdom on us as we move forward in this journey here?
No, I think we've covered it.
Well, dude, thank you so much for coming on with us. As always, I had an absolute blast.
It's a blast. Yes, thank you.
Thank you, guys.
And, we really hope that we can do this again sometime soon, have you on in the future. But we hope that all of the listeners will make some comments down in the comment section. Let us know what your thoughts are about this topic. Let us know what difficulties maybe you've had with insurance companies in going through this process, and what things maybe excite you or make you terrified about the possibility of Neuralink in the future. So with that'll be all. Anthony, do you have anything to add?
I was going to say, just let us know we got right and let us know we got wrong. We're all human, and if I need to be corrected, correct me, and I'm happy, to take that on the chin and learn from it. So,
all right, everybody, have a wonderful day.
Thanks for joining in.
I'm Dr. Joseph Millador. This is Guardia di Medicina. We are the Guardians of Medicine. My goal is to expose corruption, amplify the signal of love, and honor the sacred. This content is brought to you by Youngstown Guardia LLC. All rights reserved. Any reproduction, redistribution, or unauthorized use of this material without written consent is strictly prohibited.
I'm Anthony Fosacheca, PharmD. My mission is to uncover the realities of medicine and bring about discussion of the important issues that are currently flying under the radar. In a time where people are so divided, I want to find common ground and identify true problems rather than being distracted by emotional divides.